We'll start with the first program today, that is the Trinity approach to diabetes care, a cardio-renal metabolic approach. And this program is sponsored by Boehringer Ingelheim. And I would like to invite the moderator for this session, Dr. Amit De, to come on the dais. And Dr. Arjun Vaidya is the chairperson, who would please come onto the dais.
Very good evening, ladies and gentlemen, my dear colleagues. Today we will start our 11th DRW annual conference with the first physical program. That would be a symposium sponsored by BI. And today in this symposium we will have interactive session. We have with us the moderator, Dr. Amit Kumar De. He is senior diabetologist and physician. And the next, we have three eminent panelists. We have senior endocrinologist and diabetologist, Dr. Subir Rai, who is attached with Apollo Gleneagles Hospital. And also we have two more panelists, one cardiologist, interventional cardiologist, Dr. Sabyasachi Pal. He is attached with BM Birla Hospital. And also we have with us Dr. Joy Surya, who is a nephrologist, also attached with Apollo Gleneagles Hospital, Kolkata. So I would request all of you to join us. So we know that, where is Dr. Sabyasachi Pal? Please come on the desk. Dr. Pal. We know that type 2 diabetes mellitus is not only a metabolic disease, it is a cardio-renal metabolic syndrome. This terminology has been suggested few years back by some international guidelines and experts. And we know that type 2 diabetes mellitus are interlinked with cardiac and renal complications through the same pathophysiology, and one complications can impact the other one. So pathophysiologically, these three entities are interlinked, and also one can affect the other's outcome. So to manage type 2 diabetes mellitus, we should not have the approach of glycemic control only, but we should also think of cardiac and renal complications management. So to manage this syndrome, cardio-renal metabolic syndrome, we have to find out drugs or drugs which can simultaneously address all these metabolic and phenotypic and complications of type 2 diabetes mellitus, and so that we can have better outcome of type 2 diabetes mellitus patients. So together these three components of this cardio-renal metabolic syndrome is called Trinity, that is a triad. This is an unholy trinity. So how to break this unholy trinity with oral anti-diabetic medications, that would be discussed over the next few minutes. Now I hand over the session to Dr. Amit Kumar De.
A warm good evening to everybody, and welcome to the first session of the 11th DRWA conference. Thank you, Dr. Arjun Vaidya, for the kind introduction. A warm welcome to our panelists, Dr. Subir Rai, Dr. Joy Surya, Dr. Pal. So we will be taking you over the next 15 to 20 minutes through a case, and that case is going to be focusing on the cardio-renal metabolic continuum. And we will be discussing the case, we will be dissecting the case, and at each point we will be having our esteemed panelists come in with their expert viewpoint. So if you look at this whole continuum of cardiovascular kidney metabolic syndrome, then these are the 4 stages that you normally see. So it all starts with excessive adipose deposition, adiposity, that eventually leads to metabolic syndrome where there is a cascade of inflammation happening, leading to hypertension, triglyceridemia, fatty liver disease with diabetes, and that eventually leads to an overt clinical atherosclerotic cardiovascular disease with or without heart failure. And this then becomes a vicious cycle where there is cardiovascular disease, heart failure, various other cardiac complications, along with renal complications. So let us look at a case to start with. So this is our prototype hypothetical, or in a real world scenario also we get this kind of a cases. A 50-year-old patient who's been diagnosed with type 2 diabetes 6 months ago with no other complaints. He's been having comorbidities, hypertension and dyslipidemia for 10 years. And on asking, his chief complaint is increased breathlessness on exertion. He's obese, got a BMI of 30. Blood pressure is maintained, 120/80. His hemoglobin is low, 9. HbA1c is uncontrolled, so he's got dysglycemia, 8.1 is his A1c. He's got his cholesterols, you can see LDL is 92, triglycerides is 185. He's got elevated liver enzymes, so his OT and PT is elevated. 130 is the SGOT and 150 is the SGPT. He's got so far a good eGFR, so it's 90. And on treadmill, it is positive. So he's got a stress test positive. His echocardiography shows an ejection fraction of 58%, so that is preserved with a grade 2 diastolic dysfunction. And currently he's on metformin, telmisartan, amlodipine, atorvastatin in tolerated dose. So this is a very typical case that most of us present here would be seeing in our clinic. So the first focus that we're going to have on this kind of a patient and their parameter is the liver enzyme elevation. So my first question about this to Professor Subirai is, in a patient like this, what is the importance of screening a patient for metabolic dysfunction associated steatotic liver disease, and exactly how do we screen them?
Right, okay. Thanks, Amit. This patient is sitting on a time bomb, to be very honest with you. But even if that person's AST, ALT is not so high, he is clearly at high risk of developing muscle. Practically speaking, it is so omnipotent. It is present in 80% of the obese population. General population doesn't need to be diabetic, and more than 30 to 40% of diabetic patients, and 30% in general population. So it is absolutely present in almost everybody who suspect fatty liver disease. So you can probably screen anybody and everybody walking to a clinic with overweight or obesity problem. So when does it flag up the issue? If a person is not so obese, even if the person's AST or ALT is high, for more than 3 to 6 months, I would be flagging up the issue, and I probably screen. Of course, before screening, I'll exclude the other causes of abnormal liver function test. But the basic screen test doesn't need too much of rocket science, to be very honest with you. Just the AST, the ALT, you know the gender of the patient, the age of the patient, and if you have the platelet count, then you've got it. So you can do the FIV4 scoring, which is fairly easy. Just age of the patient, the platelet count, the AST and ALT, and there is a calculator. It is available as free. Use your smartphone, see whether it is falling below 1.3. If it is falling below 1.3, the patient has got low risk of advanced liver problem, or the patient is unlikely to progress that much. If it is more than 1.3, the patient is at risk. And if it is more than 2.6, the patient is clearly at risk. If it's more than 3.5, the patient is in advanced fibrosis state. So if I see that the FIV4 score is more than 1.3, after excluding all other native liver abnormalities like hemochromatosis, alcohol, etc., I would rather ask the patient to see one gastroenterologist, because interpretation of elastography is slightly technical. Not all of us have got the expertise to interpret either ultrasound elastography or MRPDFF. because they are slightly, super specialist thing. But the thing is, the problem lies after screening. Where do you stand? Can you offer the patient any medicine? No, because there is no medicine approved to be used in muscle. There are few medicines which are off-label. But one thing we can certainly hammer in into the patient's head, that you are at high risk of having a liver problem, and which may progress up to hepatocellular carcinoma, is as bad as that. So we can certainly emphasize upon weight reduction, diet control, so that the patient can come off the risk to some extent. Okay. If the patient is diabetic, I can probably offer the patient pioglitazone. In India, probably you can give saroglitazar as well. Okay. If the patient is not diabetic, you can probably give the patient vitamin E, especially if the patient is not a male patient. Because if you give vitamin E big dose for a male patient, there is a chance of the prostatic abnormality. Apart from that, there are few medicines which have been used, liraglutide, ezetimibe, this and that, but there is hardly any other medicines available in the market. So there you are in a limbo. You have to take the help of the gastroenterologist. So I can risk all my diabetic patients, calculate the FIB-4 score, and see where they stand, and then I take a call.
Fair enough. And this, of course, gives you how frequently we need to repeat it as per the ADA standards of care guidelines. So the next part of the patient is, and this is where I will go to Dr. Pal with his comments, is that this patient came out to be positive in the stress test. And also he's got a preserved ejection fraction, but a grade 2 diastolic dysfunction. So my question to you is, in this kind of a patient, which is very common, how do we approach the clinical screening of this kind of a patient who is also having a coexisting dysglycemia and type 2 diabetes?
Screening for what?
Screening for heart failure.
Fine. Any diabetic patient, per se, lies in the stage B heart failure. It means the patient having risk factor, but still they have not the symptoms. Our motto of the treatment is to prevent the patient shift from the stage B to stage C heart failure. And for this purpose, we have to prevent the exact insult for the myocardium. This insult for the myocardium, that is the triggering effects or triggering factors to generate the heart failure for the diabetic, either it is through ischemia or by the non-ischemic events. Through ischemia, that is already been done in this case, that is the TMT. In the positive TMT, that demands the evaluations of the coronary anatomy. And good many of diabetic patients we are getting, they are non-ischemic cause of this failure, that is called heart failure preserved ejection fractions. And to prevent the progressions of the patients from a heart failure preserved ejection fraction substates risk factor to the frank heart failure preserved ejection fraction, it demands to prevent the progression, to decrease the other comorbidities in this group of patients. Right. Control of the proper diabetes, the control of the proper hypertension, abolitions of the obstructive sleep apnea. These patients, this group of patients, they are quite obese, and the decrease in the obesity to increase in the cardiopulmonary fitness levels. So this group of patients we have to identify who are at the risks of developing the heart failure, and we have to prevent it so that we can stop the patient from entering into the frank symptomatic heart failure in the future.
Right, fair enough. The other highlighting point of this patient was having an eGFR of 90. But again, that brings us to another important segment, is that most of the time, Dr. Jaisurya, when a patient reaches to you, they're usually in the stage of stage 3 plus CKD. They don't get picked up early in the stage 2 or earlier. So how important it is, this early screening of CKD in a patient with diabetes and other comorbidities, and how can we go forward with that?
In type 2 diabetes and also in type 1 diabetes, screening for CKD is very important for early detection, so that appropriate management can be started early, which will prevent the progression of kidney disease. So in type 2 diabetes, the recommendation is to start screening for CKD at the time of diagnosis and then monitor annually. And in type 1 diabetes, at least 5 years from the time of diagnosis, we should start screening for CKD, and then monitoring is again annual. And we should use urine ACR and eGFR estimation for screening for CKD in diabetic patients. So persistent abnormalities, if you see that at least 2 times repeated over a period of 3 to 6, around 3 months, the abnormalities are persistent. That is, urine ACR is more than 30 or GFR is less than 60. In the absence of any other obvious reasons, then we can detect CKD, and management in the form of early initiation of ARBs or SGLT2 inhibitors can be started.
All right. So now, when we are looking at this cardiorenal metabolic continuum, we are talking about a molecule that can provide a synergistic action, so combination of the SGLTs and the DPP4 combinations. And this is a common slide that you often see where the DPP4 action works in synergy with the SGLT inhibition in providing that holistic control in the patients. Let us quickly look at some of the evidences that is there before we go on to the next set of questions with our panelists. So we are talking in specific about the empagliflozin and linagliptin fixed dose combination. And over the period we've seen, and also from the use of in clinical practice, that it does provide a steady control over the glycemic parameter. This is one study which kind of does the CGM, and it kind of shows that over a period of time, the combination of EMPA and linagliptin has actually provided a better glycemic profile in terms of their glycemic variability as well. Another study, and I would like a quick comment from Dr. Roy or Dr. Vaidya also on this, is the ELIFT study. It's a small RCT with 42 patients, kind of shows the superiority of using empagliflozin versus standard treatment control over 2 weeks in improving MASLT. Various other studies have been done, like this is one other study that shows empagliflozin's use improves insulin sensitivity in people with type 2 diabetes and high insulin resistance measured through HOMA-IR, fasting insulin level, and remnant-like cholesterol. The EMPA-REG outcome has actually been a very landmark study, and this has significantly showed that it offers an early risk reduction of cardiovascular death in patients with atherosclerotic cardiovascular disease coexistent with type 2 diabetes. And a lot of subpopulation study of the EMPA-REG study has also been done, and one such is the Asian patient subgroup. So that kind of correlates with the population that we deal with in our day-to-day practice. Again, a quick look at the subgroup spectrum, which is the EMPEROR reduced, the EMPEROR preserved trial, which looks at the various spectrum of the left ventricular ejection fraction. And it does show that as compared to placebo, empagliflozin does provide better results when used in the right subgroup of patients in reducing their risk for cardiovascular death, MACE, or hospitalization due to heart failure. The CARMELINA trial done on linagliptin has been kind of showing that the hospitalization or due to heart failure in terms of the event rates as compared to all the other DPP4 CVOT trial, it stands at par. So you have the empagliflozin evidence in terms of the renal and the cardiovascular safety, and you have the linagliptin evidence here. So again, the EMPA-REG outcome also demonstrated an improvement in the kidney outcome with SGLT inhibitors. Again, in all the spectrum of nephropathy, that is the incidences to worsening of nephropathy from progression to macroalbuminuria and from doubling of the creatinine rate. So another inference drawn out of the EMPA-REG outcome was it results in lower odds of experiencing rapid decline in kidney function if used in the right time. The empagliflozin facilitates regression of albuminuria in patients with type 2 diabetes and coexistence cardiovascular disease in patients who have got prior albuminuria. So if you look at the guideline recommendation of using the EMPA-LINA combination, the SGLT and the DPP4 combination, it provides a holistic effect in terms of MACE, hospitalization due to heart failure, as well as the progression of CKD, and both the molecules, empagliflozin and linagliptin, stands there, where linagliptin actually has an advantage of no dose adjustment required when patient is having a progression of the renal parameters, worsening of the renal parameters. So coming back to our case with just an overview, quick overview of these studies, the background evidences, scientific evidences that we have at hand. Let us now start understanding that what happens when we are using this medicines. And of course, we use SGLT in all our patients. And if we're not using, there should be a reason why we are not using. But there's one such limitation is using them in the sick days. So Dr. Roy, I will move on to you here in giving us an understanding that how a patient who is in a sick day condition should be managed when these patients are already on an SGLT inhibitor.
Well, sick day could be surgically sick. Sick day should be maybe medically sick. So it's not kind of synonymous. But if a person is not eating and drinking properly, or if a person is running a risk of volume depletion or blood loss, we have to be careful. One good thing about this combination of empagliflozin and linagliptin is they don't cause hypoglycemia per se. But usually, if I suspect that the patient is going to have volume loss or blood loss, I stop empagliflozin 3 days or 2 days in advance. And I restart when the patient has recovered post-stop day 2 and eating and drinking properly. The problem of continuing when the patient is NBM is again the risk of running into euglycemic DKA, which may happen if a person is having poor peripheral circulation, volume loss, etc., etc. So normally I stop oral anti-hyperglycemic agents a couple of days in advance before any major surgery. During all medical emergencies, insulin is the medicine that needs to be used, not any other weight. Once the patient is recovered, eating and drinking, not running any risk of hypoglycemia, even sulfonylurea can be restarted. If the patient is eating and drinking, it can be restarted after the first meal if I'm using Empalina. If the patient is having volume depletion, then once the volume is repleted, when the patient is off any other support therapy, I restart. So be careful about all those 3-4 days. Make sure the patient is eating and drinking, not running any risk of hypoglycemia, not running a risk of euglycemic DKA or AKI. That's what it is.
Yeah, I think that's a very important practical tip because almost all of our patients are on SGLT and we should know it, when we should stop and restart the medicines. In the same context, Dr. Pal, to you, that how should this risk of volume depletion be managed when the patients are on SGLT inhibitors, especially if the patient has got a coexisting heart failure with reduced ejection fraction or so?
On the contrary, we use these medicines for the volume, to use its property of the volume depletion. So we are running out of time. Fine. Actually, the persons of the heart failure patients who are coming to us, diabetic, non-diabetic, now around the 4 building blocks of the heart failure management, SGLT2 inhibitors is one of the biggest pillar of the heart failure patient. But what happens in the eastern populations of the India, where the body weight is very low, the patients, majority of the patients having very low blood pressure. Good many of patients does not tolerate the beta blocker. There is no question of using the ARNI-DIM. So what happens, good many of patients, they tolerates only the SGLT2 inhibitors and the aldosterone antagonist. So, barring from the patients who are tolerating the ARNI and the good amount of beta blockers, the group of patients of the heart failure having very low type of blood pressure, their systolic blood pressure hovering between some 90 to 110, there is some amount of postural drop of blood pressure, that early morning dizziness. This frail group of patients of the heart failure, if in this summer, hot summer, we are facing tremendous problem on some climatic conditions, some amount of high viral infection, any kind of high grade temperatures, some amount of diarrhea, vomitings. This group of patient does not tolerate SGLT2 inhibitors at all. So, depending on the climatic situation, so when the patient having very high, patient is living, not every patient is having the air conditioner at home. So the patients who are living in an environment where there is a too hot environment, there is an increased sweating, this group of patient does not tolerate the SGLT2 inhibitors. So the purpose of the SGLT2 inhibitors and the aldosterone antagonist or the ARNI, the beta blocker, to give the mortality benefit, but ultimately the patient has to accept this in the body. So we have seen certain situations, mainly the extreme climates, mainly some amount of viral infections when there is a high fever is going on, some dehydration, some nausea, vomiting, all these things. The patient does not tolerate any of the medicines who giving rise to drop in the blood pressure, neither the SGLT2 inhibitors also. This group of patients starts again tolerating the medicines when there is a little improvements of the systolic blood pressure. We restart the medicine as soon as their blood pressure crosses more than 110 or there is a no postural dizziness. At least we cannot measure them the postural drop of blood pressure. At least there is no postural dizziness. So using the SGLT2 inhibitor, some amount of practical in case of this type of year when there is extreme summer is going on. So this is our experience.
Right. So almost at the end of time, but another important practical concern that happens, Dr. Jayasuriya, is once we are starting a patient on SGLT, there is usually a initial decline in their eGFR and a rise in creatinine. So how much of that is permissible and what should ideally be done in those cases?
We usually see a rise in creatinine or a drop in GFR immediately after, within the first 2 weeks of starting SGLT2 inhibitors. Up to 30% drop in GFR is permissible. If the drop in GFR is within this limit, you have to continue using SGLT2 inhibitors and keep on monitoring, maybe repeat after 3 to 4 weeks. And then if the GFR is stabilizing, you can safely continue the SGLT2 inhibitor.
Fair enough, valid point. So I think that brings us to a crisp end to the case. But before we end, I will hand it back to Dr. Boido. And a quick comment from you also on the studies that we showed, especially the study of empagliflozin, a small population study done to show some impact in MASLD, and your overall impression on the EMPA-REG outcome. With that, you can conclude.
Thanks, Amit, for nicely conducting this session. So, with regards to EMPA-REG outcome studies, I think this is empagliflozin, which has been tested in this dedicated cardiovascular outcome trial. Almost all the patients had atherosclerotic cardiovascular disease, established atherosclerotic cardiovascular disease or events. So this was primarily meant for secondary prevention, and though the other outcomes also showed benefits, and hospital and heart failure benefit, and also renal outcome benefits. And regarding the ELIPT studies, the study have shown its benefit in reduction of the liver fat content. But what about the regression or the reversal of the fibrosis? That outcome, the studies with that outcome is not yet, I think, yet with the any SGLT2 inhibitor. So overall, I think SGLT2 inhibitor as this class of drug reduces the body weight, therefore ultimately it improves the insulin sensitivity, and it also reduces the visceral fat contents. That's why theoretically it is beneficial, and that's why it is helpful in MAFLD patients, I think.
Right. So thank you. That brings us to the end of the session. Thank you very much. Thank you to all our panelists. And
thanks all the panelists and also the moderator, Dr. Amit De, for nicely conducting the session.
Now we move on to one of the theme of this conference today is the metabolic health bridging research and clinical practice. And we now start the metabolic symposium, and for that I call on to the chairpersons, Moshid Aslam, Dr. Amal Bhattacharya, Dr. Shankarnath Jha. Please come onto the dais. You have the CV in front of them. And the topic today is metabolic syndrome, criteria, diagnosis and management updates. And the speaker is none other than Vinay Dhandania. Please introduce us.
So, very important topic, metabolic symposium. None of the disease related to metabolism is complete without the discussion of metabolic syndrome. We call upon Dr. Vinay Dhandania to talk on metabolic syndrome, criteria, diagnosis and management updates. We know the disease for long, but every year there is a change in definition. Some criteria are added, and a lot of trials are going on to see what can reduce the fat deposition in the liver. So over to Dr. Vinay, please.
Respected seniors, dear friends, respected chairpersons, thank you for this opportunity. It's my great pleasure to be invited as a speaker for this 11th DRWA meeting. I'm going to talk on metabolic syndrome, and it's very interesting to see a topic been selected at the beginning of the conference, because this is one topic where we can actually act both ways. We can actually prevent diabetes, we can prevent major complications of diabetes if you start treating intensively, picking patients intensively, and at the same time you can also predict the ongoing metabolic disturbances in an individual who is in a community. So we have been seeing this transformation, the shape of the things to come, and abdominal obesity plus two other components like elevated blood pressure, low HDL, elevated triglyceride, or impaired fasting glucose makes the definition of metabolic syndrome, and it is defined as constellation of metabolic abnormalities that confer increased risk of cardiovascular disease and diabetes mellitus. There are a lot of alternative names for this: metabolic syndrome, syndrome X, insulin resistance syndrome, deadly quartered, Revens syndrome. Revens was the first to actually coin this terminology. So this is the IDF criteria, which is very, very common. And the IDF criteria actually includes the west circumference according to the region. The Southeast Asia, the west circumference for males is more than 90, and for females is more than 80, plus two or more of the following: hypertriglyceridemia more than 158 triglycerides, low HDL cholesterol, that is less than 40 for males and less than 50 for females, and hypertension, that is blood pressure more than 130 millimeters of systolic or 85 millimeters of diastolic, and fasting plasma glucose more than 100, or on specific medications or previously diagnosed with type 2 diabetes. So this is how it is been defined. And the important thing is, if a person already has got a body mass index of more than 30, you need not measure their waist circumference. So they fall into this category of metabolic syndrome with two more factors included. Now, how do you measure this? This is always a debate and controversies, a way to measure. It's very well defined that locate the upper hip bone and top of the right iliac crest. Place measuring tape in horizontal plane around abdomen at the iliac crest, and the tape should meet the other iliac crest on the left side. Ensure that the tape is snug but does not compress the skin. Tape should be parallel to the floor, and record measurement at the end of a normal expiration. So this is very, very simple. The major features of metabolic syndrome include central obesity, hypertriglyceridemia, low HDL, hyperglycemia, and hypertension. There are a lot of other additions to this which we are going to discuss in near upcoming slides. Epidemiology, its prevalence has increased with age, and greater industrialization and urbanization is one of the reasons. Increase in breast circumference is found predominantly in women. Fasting triglyceride more than 150 and hypertension are more likely to be present in men. The risk factors is overweight or obesity, mainly central obesity, sedentary lifestyle, predictor of cardiovascular disease events and associated mortality. Associated with central obesity, triglyceride, HDL, cholesterol, blood pressure, and glucose intolerance. Recently, we did a very small observational study in one of the coaching classes, Akash coaching classes in Ranchi, because one of his the director of that Akash classes was my patient. He said we can do some observational data. They had 300 students in one batch, and the students' age were between 15 and 18. So what they found was almost 20% of the students in the age of 15 and 20 were either overweight or obese. And you can imagine, with their sedentary lifestyle focused on only in their studies and food, what is going to happen in near future. And out of 5 to 10% of the female students already had irregular menstrual cycles or delayed menstrual cycles with obesity. Some features of early PCOS was also seen in them. So the feature of metabolic syndrome is starting very, very early in the course of life today, and we need to address this in the community from the school era itself. Unless then we can prevent it, and we can prevent the long-term complications. Aging is again, prevalence increases with age. Diabetes mellitus, approximately 75% of the type 2 diabetes or IGT have metabolic syndrome. And this was also seen in the ICMR INDIAB study, which was published in 2022. The ICMR INDIAB 17, which was published in Lancet. And there they found that almost 70% of the people had either obesity or higher waist circumference ratio. Coronary artery disease is 50% of CSD patients have metabolic syndrome, and about 1/3 of metabolic syndrome patients have premature CAD. Now, you must have seen a very recent article published, I think yesterday or day before yesterday, by Dr. Rajiv Gupta from Delhi. And what people are saying is very early, very commonly seeing early age of CAD, premature CAD in the community. And what they are actually thinking, the most of the press people are actually accounting to be associated with COVID vaccination and a lot of COVID which had happened in the past. And Dr. Rajiv Gupta very, very clearly mentioned that it's the changing lifestyle, the stress and the obesity, what has caused to premature coronary artery disease in younger individuals. And metabolic syndrome is one of them. So lipodystrophy, both genetic or acquired, have severe insulin resistance. And lipodystrophy people are not obese, believe me. They have very loss of muscle mass with higher triglyceride values, with they have a fatty liver and very fastly progressing NASH to cirrhosis of liver. So lipodystrophy is another genetic severe insulin resistance syndrome which is there. Clinical features usually asymptomatic, and high index of suspicion is needed for diagnosis. And examination is very important. Increased waist circumference, increased blood pressure, lipoatrophy, acanthosis nigricans, skin tags, they all are seen in clinical practice. I'm telling you, for a simple GP, if a person comes with fever, cough and cold, he can see all these features in the same individual. So just not treating them for cough, cold and fever and diarrhea, you should always caution them that this is what we are moving on. I heard Dr. Subir talking about sitting on a time bomb. So people with metabolic syndrome are sitting on a time bomb, and they are going to have a lot of future possible complications. So this is how it is. It looks, the acanthosis at the axillary fold, the neck fold, the tags, and also at the inguinal fold, skin fold also you see these tags. Other associated conditions are cardiovascular disease, type 2 diabetes. NAFLD and NASH is again a very big problem which has been associated with metabolic syndrome. And there are a lot of data to suggest that children with in the age group of 15 and 20 are getting NAFLD because of metabolic syndrome, and they are not diabetic. And 5 years down the lane, almost 20 to 30% of these children are becoming diabetic. So probably NAFLD and metabolic syndrome together are one of the risk factors for young onset type 2 diabetes. Hyperuricemia, PCOS prevalence is now 40 to 50%. And I have my notes of my MBBS time where we used to have 5 to 7% of PCOS in the community. I'm talking about 94, 95, which is now almost 40 to 50% today. OAC is again a very, very big problem. Obstructive sleep apnea, commonly associated with obesity, hypertension, insulin resistance, and CPAP is known to improve insulin sensitivity. So this is again a very interesting slide, and you need to understand how insulin resistance actually causes type 2 diabetes. Now, insulin resistance causes type 2 diabetes by two important phenomena. First is endogenous production of glucose. There is an increase in endogenous glucose production at the level of liver. And secondly, because of the continuous insulin resistance, there is loss of first phase of insulin release. So both insulin resistance, beta cell defect are actually known to cause type 2 diabetes with metabolic syndrome. Hypertension, the association of hypertension, especially essential hypertension and insulin resistance, is not very well established. But there are few hypotheses and studies which has been done, one of them being abnormal RAS system, and secondly, there is an increase in peripheral vascular resistance. And we all know that peripheral vascular resistance is the key factor in measurement of diastolic blood pressure. So if your peripheral vascular resistance is going to increase, your diastolic pressure is going to increase, and further leading to even systolic blood pressure. Impaired glucose tolerance, obesity, central obesity, polycystic ovarian disease is again one thing which is very, very common. It's because of hyperinsulinemia acting at the IGF receptors at the ovaries, and leading to a formation of increase in testosterone and androsterone, endosterone hormones, leading to polycystic ovarian disease. Hyperuricemia is again very important because insulin is known to cause a reabsorption of sodium and uric acid at the level of renal tubules. So when you have insulin resistance, there is more of hyperinsulinemia and more of uric acid which has been reabsorbed, and that leads to hyperuricemia. Acanthosis nigricans is again at the level of skin folds. You have IGF receptors which are actually increasing thickness of the skin. Decreased fibrinolytic activity, this is again because of increase in PI1, plasminogen activator inhibitor 1, and plasminogen activator inhibitor 1 is supposed to be inhibiting fibrinolysis, and that is again causing more of coagulation disturbances and increase in MI and CAD. Dyslipidemia, mainly high triglyceride. This is again because of impaired lipogenesis by the insulin. Insulin not only causes decrease in glucose values, but it also causes lipogenesis. So there is increased lipolysis, increase in non-esterified fatty acids, that is actually leading to more of dyslipidemia. And atherosclerosis is basically a combination of everything because of endothelial dysfunction and increased onset of atherosclerosis. And this atherosclerosis is modifiable. This is not a non-modifiable atherosclerosis because this is one thing which you can modify and correct it. So insulin resistance, increased breast circumference, dyslipidemia, this all leads to basically increase in inflammatory markers, especially interleukins 1, 6, and 18, resistin, TNF-alpha, CRP, and adiponectin is again, which was talked in the last presentation as well, an anti-inflammatory cytokine is reduced in metabolic syndrome. This is a protective hormone which has been released by the adipose tissue, which is reduced in metabolic syndrome. So this is another graph which suggests that how actually different factors leads to contribution of metabolic syndrome, and this metabolic syndrome in fact how it causes hyperglycemia and type 2 diabetes by directly causing toxic injury to the pancreatic islets. As I said, first phase of insulin release is abnormal, then increased in insulin resistance at the level of skeletal muscles, at the level of liver, and impaired insulin mediated glucose uptake even at the level of skeletal muscles, because there is resistance at the level of GLUT4 in skeletal muscles. At the same time, there is a tyrosine pyrophosphate receptors which are abnormally functioning at the level of skeletal muscles. So this is the flow chart, how actually it perpetuates coronary artery disease with central lobe adiposity and hyperinsulinemia. So how to diagnose it? The important thing is you have to see the patient and you can say that this patient is having metabolic syndrome. Seeing a patient, examining a patient will tell you what all things you are actually looking into him. So history of symptoms of OSA in all patients, PCOS in premenopausal women, family history of premature CAD and diabetes, waist circumference and blood pressure management, laboratory investigations like fasting lipid profile, fasting glucose, HSCRP, fibrinogen, uric acid, urine microalbumin, LFT for NAFLD, sleep study for OSA, and testosterone. Even testosterone is less in male patients, and they improve by doing physical activity because at the level of adipose tissue, there is a metabolism of testosterone. The sex hormone binding globulin is impaired because of adiposity. So treatment is very, very important because this is one treatment which can help in prevention of a lot of complications
Sir,
in an individual.
2 more minutes, sir.
Yeah, 2 more minutes. So weight reduction is very, very crucial. For weight reduction, you need to have more of behavioral therapy, and the most important behavioral therapy is self-realization. You have to tell your patient you need to have self-realization for weight reduction, only then it can happen. Diet, for diet, you just do a dietary assessment first, what the patient is eating for last 7 days. A dietary assessment for last 7 days, make a dietary recall, and that will tell you how much of calorie this individual is taking. By just cutting down to 500 kilocalories, you can lose 1 kg in a month. So you need to modify the carbs. There is a myth that by reducing fat in your diet, you will reduce your triglyceride. But for reducing triglyceride, you need to cut down on carbohydrates in your diet. It's not basically fat in your diet. Physical activity is very important, 60 to 90 minutes of daily activity, and you need to ask your patients to start first and then escalate it gradually. Whatever type of physical activity they are comfortable in, they should start. Obesity is again very important. Try to treat obesity with lifestyle manifestation and again by behavioral therapy, physical activity. If all together, you can also add some medicines like appetite suppressants like phentermine, absorption inhibitors like orlistat, GLP-1 receptor agonists like liraglutide. We have approval for liraglutide, semaglutide, and even tirzepatide, which are now going to be available shortly in our country. Bariatric surgery is also an option for patients with BMI more than 40, more than 35 for patients with comorbidities. Last 1 minute, sir, just 1 minute. For triglyceride, you should maintain less than 150. HDL cholesterol, you can increase by weight reduction and physical activity. LDL cholesterol less than 100, and try to treat blood pressure as intensively as possible. You can treat insulin resistance by 2 important drugs in our basket, biguanides and thiazolidinediones. And it's very important to understand if you have all the features of metabolic syndrome with hyperglycemia, try to reduce the hepatic glucose output instead of improving the uptake of glucose in the liver. You should be treating the other way around. Try to inhibit, use drugs which actually prevent hepatic glucose output, and not that increases the glucose uptake in the liver. So glycemic control is also very important. Prothrombotic and pro-inflammatory state can be treated with aspirin. So metabolic syndrome is common and a growing problem in India. It is associated with substantial morbidity and mortality with cardiovascular disease, diabetes, and stroke. Early identification and treatment can prevent these complications, and consider developing a strategy for this problem that you can implement in your practice. So I thank you all for your patient listening. Thank you.
Thank you, sir. Sir, one of the, initially you've mentioned that one of the studies done in Akash, they are told 20%.
Yeah.
But actually it is more than 20% what we are seeing nowadays, especially even in urban, rural areas, the prevalence is increasing.
Agree. I mean, this was what we did in our Akash Institute on that particular batch of students. Yes. We have not done a very big data. It was just a data which we collected because the director was visiting my clinic, and I was sharing with him, this is what is happening today with your students. And he said, yes, Doctor, we see a lot of obese children in our institute as well. So he allowed me to collect the data. We sat there for Saturday and Sunday, examined almost all their anthropometric data to see what was happening as far as their weight and obesity was concerned.
Sir, waist circumference also was checked?
Sorry?
Waist circumference.
Yeah, definitely. We did waist circumference. I'm telling you, this is what we did. But the thing is, 15 to 17 years old, they don't have too much of waist circumference which is abnormal. They have a good obesity, overall obesity, which is BMI close to between 28 and 30. There are a lot of children with 28 and 30.
And we're seeing nowadays a lot of type 2 diabetes in 15 to 17.
Yeah, exactly. So that was the basic idea of going into Akash classes. I took one session also for these children to explain them. You see, what is happening almost in class 9 and 10, only studies and mobile and internet. 11th and 12th, coaching classes, school, padai, and nothing else. Then you enter IIT and medicine. What do you do there? Then after IIT, you get a job. 24/7, you have a laptop and a mobile phone. Next 10 years, you work, and then you visit your doctor. So this is what is happening. See, this is what is happening, sir. The whole sequence is starting when they are in class 8 or 9. That is where because 99% marks, sir, NEET, they are getting 100% marks, sir. We can never imagine something like getting 100% marks in NEET, isn't it? So if that is the type of competition which is happening, there has to be, and the stress which these children have. Don't forget that the stress these children are having, sir, in scoring those marks and studies and competitive exams. So everything is piling up, and they are actually adding to the problem of metabolic syndrome.
Yeah, we fully agree with you, sir. Overall data from our country says the prevalence is around 30%.
Yes, sir.
And we all agree that it is increasing day by day due to the lifestyle factors.
Yes, sir.
And it is right time to talk about metabolic syndrome in every forum. Yes, I congratulate, like the other chair already said, that they have included this, and we should talk about metabolic syndrome in every forum. Thank you so much.
Thank you, sir. Thank you very much.
Next one.
Thank you.
Now I welcome Dr. M. Sumugam Velu. Welcome, sir. Sir will talk about ethical considerations in the treatment of metabolic conditions. Sir is Chairman Academic of RSSDI, Tamil Nadu chapter, and past Secretary of RSSDI, Tamil Nadu chapter. He has served in Tamil Nadu Medical Services for a long time and is now Regional Faculty of Public Health Foundation of India, New Delhi. Published many articles, and he was honored with Professor Dr. Ram G.P. Das Moses Oration Award and many awards. Welcome, sir. The podium is yours.
Thank you, sir. Thank you very much, respected chairpersons, senior doctors, my doctor friends. I feel extremely happy, honored, and most privileged to have been invited to make a presentation on ethical considerations in the management of metabolic condition with a particular focus on evidence-based findings. I thank the chairperson for the nice introduction. Also thank Professor Dr. Patni for his kind invitations. My disclosures, of course, I have no conflict of interest in relation to my presentation. What I'm going to do for another 17 minutes. The contents of a top line includes introduction, ethical considerations, achieving optimal glycemic goals, and addressing MASLD and conclusions. So, defining responsibility of a practicing physician is to make decisions on patient care in different settings. These decisions involve more than selecting the appropriate treatment or intervention. Ethics is an inherent and inseparable part of clinical medicine, as a physician has an ethical obligation to benefit the patient, to avoid or minimize harm, and to respect the values and preferences of the patient. It's a broad term that covers the study of the nature of models and the specific moral choices to be made. Four principles that constitute ethics are beneficence, non-maleficence, autonomy, and justice. Beneficence and non-maleficence can be traced back to the time of Hippocrates, to help, do no harm, while autonomy and justice evolve later. With the passage of time, both autonomy and justice gain acceptance as important principles of ethics. So the principles of beneficence, the obligation of physician to act for the benefit of the patient, supports a number of moral roots to protect, defend the right of others, prevent harm, remove conditions that will cause harm, help persons with disabilities, rescue persons in danger. So the principle calls for not just avoiding harm, but also to benefit patients and also to promote their welfare. Non-maleficence, obligation of physician not to harm the patient. Do not kill, do not cause pain or suffering, do not incapacitate, do not cause offense, and do not deprive of others of the goods of life. So for the physician to weigh the benefits against burdens of all interventions, treatment, to eschew those that are inappropriately burdensome, and to choose the best course of action for the patient. So ethical principle, all persons should have intrinsic and unconditional worth. They should have the power to make rational decisions, moral choices, and they should be allowed to exercise his or her capacity for self-determination. Justice, interpreted as fair, equitable, and appropriate treatment of persons. So the distributive justice refers to fair, equitable, and appropriate distribution of healthcare resources determined by justified norms that structure the terms of social cooperation. So the goals of ethics education, to appreciate the ethical dimensions of patient care, ethical principles of medical professions, competence in core ethical behavioral skills that includes obtaining informed consent, decision-making capacity, discussing resuscitation status, use of life-sustaining treatments, advanced care planning, breaking bad news, and effective communication. To know the commonly encountered ethical issues, to have competence in analyzing and resolving ethical problems, to appreciate cultural diversity and its impact on ethics. So ethical consideration with reference to our problems. So metabolic, that is Indian Council of ICMR in-depth study, that is a cross-sectional population-based study, assess the representative sample of individuals aged 20 years and older, drawn from urban and rural areas of 31 states. They looked into the prevalence of metabolic disease in India with reference to diabetes, pre-diabetes, dysglycemia, hypertension, generalized obesity, abdominal obesity. So the prevalence of diabetes and other NCDs in India is considerably higher than previously estimated. So the prevalence of diabetes was 11.4, pre-diabetes 15.3, hypertension, generalized obesity, abdominal obesity, and dyslipidemia are shown in this particular slide. Achieving optimal glycemic goals. So this thought study, conducted by Shashank Joshi et al., they assessed the total and complex carbohydrate content. The cross-sectional study also provided a good opportunity to assess the glycemic control in patients with the type 2 diabetes. So the data clearly shown the fact that nearly 67% of the patients do not achieve the glycemic targets in India. Kindly look into the fasting plasma glucose, postprandial plasma glucose, and A1C. Only 33.1% of the diabetic population had A1C less than 7. Nearly 63% of diabetic populations were above the target postprandial blood glucose value of 180 milligram. Naturally, they are exposed to prolonged period of uncontrolled hyperglycemia, greatly increasing the risk for diabetes-related complication. Ethical dilemma in diabetes management. Hyperglycemia is a strong risk factor for microvascular complication. It is one of the major risk factors for atherosclerotic cardiovascular disease. We try to achieve optimal levels of glycemic control with a view to reduce the diabetes-related complication. At the same time, over-treatment results increase the risk of hyperglycemia, also weight gain. So, ineffective diabetes management results in suboptimal glycemic control. In research-poor settings, medication non-adherence as well as therapeutic inertia contributes to the suboptimal glycemic control. So, if you look into the health risk from intensification of medical therapy, it represents an ethical dilemma between averting the risk from over-treatment, preventing harm from raised blood glucose levels. So, there is a balance. So, we need to consider. So, the desired efficiency in terms of therapy intensification to achieve glycemic goal. At the same time, avoiding harm, avoid over-treatment, and reduce the risk of hypoglycemia as well as weight gain. So the ethical challenge of balancing desire for beneficence, that is improvement in glycemic control, while avoiding harm, that is inadequate therapy and a hypoglycemic episode to patient is well established. So DCCT, follow-up ethics study, 30-year study, clearly shown the benefits in the intervention group compared to conventional glucose control group. 30% risk reduction for any CVD and a greater risk reduction of less frequent fatal events than non-fatal events. Next is Cochrane Laboratory. Data clearly shown. Intensive group, the risk of hypo increased for patients who started with relatively low A1C value. Several of the included studies also showed greater weight gain under intensive glucose control. Intensive glucose control was highly effective in reducing the risk of developing microvascular diabetes complications. Next is very important, clinical inertia. Type 2 diabetes is a progressive disease. So multiple intervention will need to be used while managing diabetes as the duration advances. So timely treatment of patient with the type 2 has a beneficial effect on outcomes. So the conventional sub-care approach, treatment to failure approach, substantial inertia exists at each sequential intensification step. So we initiate the patient on basal insulin, and there is a delay of more than 3.9 years with reference to intensification. So for patients clinically eligible for intensification, there was a median time of 3.7 years from starting basal insulin until intensification. So there is a significant delay in the intensification. This may have a negative impact on the long-term outcomes for patients. So the conventional step care approach, treatment to failure approach, patients are exposed to longer periods of uncontrolled hyperglycemia, increasing the risk. On the other hand, earlier intensification with the combination that is recommended to achieve and maintain the target goals. So an earlier and more aggressive intervention approach provides more rapid glycemic control, improves patient's glycemic profile without significantly increasing the incidence of side effects, and it has been recommended by most of the leading associations. So consequences of delayed intervention. Two groups of patients. Patient with a similar A1C, given IT treatment, you see at the end of the 5.3 years with reference to myocardial infarction, stroke, and heart failure. On the other hand, patients not given intensive treatment, you see the risk for myocardial infarction as well as stroke. That tells you the dysglycemic legacy which may drive the risk for complications. So clinical inertia results in prolonged periods of uncontrolled hyperglycemia, increases the risk of diabetes associated complication, and reduces life expectancy.